good evening. Welcome back again. Here at the CAT Lab number 1 in Favaloro Foundation, University Hospital, Dr. Fava, Dr. Juan, Claudio, Matias as a nurses, Dr. Agomez here, and Jessica as a technician. Dr. Agomez is the anesthesiologist. And Dr. Andres Rodriguez is gonna follow as leader for the questions. So please, I push to everybody to send us as many questions as you want. As I told you, I have to change the plan. I do apologize for that. The patient that we have sent for promotional slide yesterday is a case for a TAVI case with the previous conduction disturbances. We did it during the break here in Favaloro. We implanted a 29 Evolut valve, and so far there is not any new conduction disturbances. Anyway, the patient is under, with a transient pacemaker just in case, and he is going to be in the hospital at least until tomorrow afternoon or evening, and we will discuss tomorrow with the clinicians and so on when we can discharge this patient with such a complex conduction disturbances before. So, but the problem today is we have this nice man with some problems, and we had to treat emergently. Let's introduce the case with the slides, please. Let's go with the next. So he is a 77 years old male. He's suffering from a trauma. He fell down at home and fractured his pubic, and also when he was studying, they found a huge iliac aneurysm. He has history of hypertension, heavy smoker, alcoholism. He has liver disease under investigation here by our colleagues in the hospital. He is a patient with potential cirrhosis, but still not confirmed. And he has suffered due to this fall pelvic trauma. And as I told you, multiple fractures there. Next. So the ECG is normal. The blood test is some anemia. With all the other parameters are okay, but he developed a little bit renal failure or renal toxicity after the CT scan. So we have to be very careful with the contrast media to be injected during the procedure. He is obese with a body mass index of 38. The cardio echo Doppler showed preserved left ventricular ejection fraction. The MRI showed the lumbar vertebra number 3 fracture. And also the angiography CT showed a weak left common iliac artery aneurysm with a retroperitoneal hematoma. So it's not possible to confirm if it is bleeding due to this aneurysm or it's bleeding due to the fractures. But anyway, next. So this is the angio. So it's a huge iliac aneurysm with calcifications on the beginning of the common iliac artery, almost no proximal neck to treat only this vessel. Next. The abdominal aortic measurements I already did in the morning is 11 centimeters from the renal arteries until the carrefour. The diameter of the proximal aorta below the renal is 21 millimeters and 30 at the near to the carrefour. Next. And this is the right iliac artery. The common iliac artery diameter is 15. We have another measurements which is a little bit bigger, like 18 or 19. That's why we are going to use a bigger branch there. The external iliac artery is also huge. I think measurement is 11. Next, and excuse me, the length of the iliac artery, the common iliac artery is 7 centimeters. Next. So this is the huge aneurysm on the left common iliac artery with almost no proximal neck, which is also dilated. It's 18 millimeters there, so it's almost impossible to get the correct sealing if we use only a device to cover this aneurysm without treating the abdominal aortic bifurcation. So the aneurysm extends until the bifurcation involving the ostium of the hypogastric, and then there is a normal external iliac artery. Next, the diameter is 60, almost 60, or yes. So in summary, it's a patient with a pelvic trauma requiring surgery, but orthopedic surgeon asked us to solve this vascular situation because nobody knows if this retroperitoneal hematoma, once again, is due to the fractures or due to a vascular compromise of this aneurysm. Next. So our strategy is to do a bifurcated EVAR device with the previous left hypogastric artery embolization. We have planned to do, actually, we have already done a percutaneous femoral access. We called our colleagues here for surgical standby, just in case we have bleeding. Coils embolization for the left hypogastric probably would have been easier and faster to do a plug embolization. But, you know, once again, we have to deal with health insurance here. So we don't have coverage for a plug. So we have to use coils. And then a bifurcated EVAR prosthesis extending until the external iliac artery on the left, just to cover all this huge aneurysm. Next. So let's go back to live. I will show you what we have already done. We, Carmen, pay attention to the blood pressures. Carmen, fíjate la presión. So we did first the left vascular access and the angio and echo guided. Next. So there is some tortuosity. We have some difficulty because there is a very high bifurcation. Anyway, I think I am not in the ideal place. It should have been a little bit higher. Next. And then we have decided to use the old ProStar. Once again, I told you in the case before how to use it. Next. Then we did an angio to check the right common femoral artery. As you can observe there, this is a big artery with a very high bifurcation with a huge superficial femoral artery. At the beginning, I thought about to go the superficial because it's big enough to introduce a device. But anyway, I decided to go back to, to the usual procedure and going a little bit higher to be or to stay in the safest part of the common femoral artery. Next. In the common femoral artery, yes. This is, well, the puncture. Next, let's go. Little bit radiation in my hands. Next. Let's go fast. So we introduce a 6 French, then the ProStar. Next. Once again, being very careful because the patient is heavily obese. You can observe there the twist of or the kink of the pusher due to the obesity of the patient. There you can observe on my index on my fingers this kinking. Next. And then we did a test after introducing an 11 French sheath, where I have in both sides, to put a wire on the superficial femoral artery just in case a catastrophe, because from there we can introduce a balloon to, close the external iliac or the common femoral artery in case we have a severe bleeding that we cannot control and we need the help of the surgeons for surgical repair. Although we can introduce from there a cover stent if it is necessary. Next. We did again from the protection for the other side. As you can observe, I am just about of the bifurcation. I would like to be a little bit higher. Hopefully, it will not bring problem when we are closing at the end. This is probably the more challenging situation that we will face when we finish. Next. So we did this angio. You can observe there how huge is this aneurysm with calcification on the hypogastric artery. We have a landmark there where to go. Next. So we have introduced the SIM catheter, SIM number 2. The one was too small. And then we went into the hypogastric artery. Next. So we introduced a microcatheter and we decided to coil embolization with 018 detached coils from Cook. Next. We deploy a lot of coils there. I don't remember how many. There are 14, the Nestor coil, sorry, 14 by 20 millimeters. No, 14 millimeter by 20 centimeters. Excuse me. Let's go. Then we pull back or retrieve the microcatheter. We introduce a couple of bigger coils, 035. The idea is to just not to completely seal in, but to have at least a good nest for coagulation there. So this is where we are. Next. And then we did this artography, where once again, we can observe the huge aneurysm with almost no neck. Just to let you know that in many cases, we have tried different solutions for that. We have used cover stent, self-expandable stent, balloon expandable stent, and even in one case, we have implanted one stamp of the EVAR device from contralateral side, so that we have the huge part in the beginning of the aneurysm and the smaller part on the external iliac artery. All what we have tried, to be honest, I would like to tell you that it's not a good solution in the long run. That's why when we have huge iliac aneurysm with short, less than 20, or I would say less than 25 or 30 millimeters in length of the proximal neck, we would rather like to go with a bifurcated device to be sure that this is going to be a complete sealing for the follow-up. Next. Then we introduce a marked pigtail just to confirm the measurements I did in a rush in the morning. But as you can observe from the right renal artery, which is the lower, the distance from there to the carrefour is probably 10.5 or something like this, in concordance with the measurements I did. So we have decided to use 28 device. Remember that the proximal neck is close to 20 and distal is 30. One of the problems when we do this kind of procedure, EVAR, and I would say so-called normal aortas would be if it is the distal aorta is too small to contain the two branches for the device and not collapsing them. In this situation, probably we have to change the device, probably like one quadrimodular device, like the Ancura device, or very new design of devices for this very small distal carrefour. So where we are now, no, we are here now, sorry. So we have both Amplatz wire in place. I will introduce here the shear 4 catheter to have control of the proximal landing zone on the lower renal artery. I will try to put this shape 4. Sorry. The shape 4 catheter on the right renal artery. And then we have already prepared a 28 by 85 body of the Cook device, the Zenit device. Sorry, give me there. Give me a little bit more radiation, because probably for public is not seen very well because the patient is a huge body. Text. So I have to put this catheter almost at the level of the right renal artery test. So we are there. So I will leave the catheter there. I will extract the wire. We have flushed the catheter of the main body of the graft. So Dr. Carlos is going to hold the groin. I'm going to bring the device, which is here. It is flush. The port should be it's not perfectly flush. We have to flush again because we have some air. You flush. You have to pay attention here because water is falling here and on the top, and it can flash on in your face. So now Dr. Carlos, please zoom out a little bit so we can see more panoramic from the camera, from this camera. Could you do, could you unzoom, please, from the camera number 2? Well, I don't know if somebody is hearing me. Dr. Carlos is not holding enough in such huge body with a lot of tissue there, which makes okay, makes difficult to compress. So let's. So once again, I have to hold this part of the device on the right orientation. So we have the contralateral stump orientation to the left. So I am going in. It's very easily to advance. Then, okay, move para allá. Okay, these markers are showing you where the graft starts. And the proximal part is the fixation stent. And please zoom. Vos, Claudio, zoom. So here, for those who are not familiar, we have like a sign that when we have a check sign here, that it means, or it shows you that the orientation of the contralateral stump is correct. Additionally, Dr. Fava is going to test the renal. I have lost the position of the renal test. So we are too high there. Remember that in this case, necks is very long. There is no problem with short necks. So I'm going to be below the renal. Test again. Be sure. And there, the contralateral stump is released. And it's perfect on the other side. Now, I'm going to pull the catheter. I'm going to ask my colleagues for an hydrophilic wire to catheterize this contralateral stump. So please ask questions. Or I would rather like the road runner, but let me try with this. Please, the pin. Okay, oh, this pin is not the best, especially for the afternoon. If somebody from the company is watching, you have to modify this pin. No, give me the road runner, please. Oh, espera un segundo. And there, it's important to see on lateral views. So to be sure you are pointing, it's better the straight wire. I don't know why Matthias gave me this angulated wire, but I don't like for this, especially when you are in a hurry. No, let's go to the other. A la izquierda. Okay, let me see. This is probably the more difficult part, although especially when you have small annulus, a small aorta. I think I am in now, although I am using the enemy's wires. Now I have to be very careful not to lose in the position because there is angulation there. Let's go frente, Claudio. So here I have to rotate the catheter because this wire is doesn't have enough support. Anyway, I'm sure I am in. This is important to check that you are inside the body before introducing stiffer wire and not in parallel. So let's go up, Claudio. So now I have to release the security. of the proximal cap. I am releasing this wire, which is for secure the proximal fixation system. And now I open here, I'm pushing here, I'm gonna deliver it. You will see how the proximal part of the stem graft is gonna be open. I will leave it there up, just in case of any movement. I'm not moving the device. Once again, I rotate this catheter to be sure that I am in. It's not possible. So I would probably work with the regular J wire because I'm scared to lose the position because there is a lot of tortuosity there, just to introduce the implants from the beginning. Let me introduce first the regular wire. Then I can advance the catheter very distally. And now I'm more confident to advance the implants wire. I always make a loop. Just this wire is not gonna go to any branch in the aortic arc or something like this. Something that I am not observing from here. So from the, it's okay, demostrame abajo. So now on regular procedures, and okay, on regular procedure, we have to measure which is the distance between the main body and the bifurcation of the common iliac artery. This is not the situation in this patient because we are going to cover all the way long until the external iliac artery. The external iliac artery is about 10, 11 millimeters in diameter. So we are going to use at least 2 long stumps. The first one is 13 by 112. Yes, and then there's going to be another with similar length. Okay, so we are going to open this. Dr. Carlos is going to flash. Yes, please, questions. Good. Regarding the first question, let's go because I am old. Probably I forget the next question in a minute. Why we should embolize this artery in that huge aneurysm? Because if we put the cover endograft going from the main body until the external iliac artery, when you perform the injection, you will only see the contrast media going in this inside this stent until the external, and you are not going to see anything else, and probably you're going to be very happy with the outcome. But then you are going to have flow back from the hypogastric artery until the aneurysm, filling the aneurysm, pressurizing, and keeping the risk of this aneurysm rupture. So you have to close these arteries always. If not, the aneurysm is not completely sealed. Hopefully I am being clear. If not, please let me know. So the second question, give me a second. This is the contralateral stump. This is once again is 13 millimeters in diameter, which is the distal part. I forgotten to thank Alejandro from Cook, who is helping us in this immersion procedure. So we are going there. There's tortuosity. So probably we have to use a stiffer wire. Let me see if I can advance. If not, I'm going to change for a Landerquist. Please, let's look for a Landerquist wire. Yes, let's change. I need your help here to compress. Vos agarrar la guía, Carlos. So he is going to hold the groin. I'm going to pull the device out. I'm going to introduce the catheter distally, and then I'm going to introduce the Landerquist wire, which is stiffer wire and probably would facilitate the advance of the device. If not, I'm going to pre-dilate the ostium. where there were, mostrame más arriba, there were some calcification there, which I think are interfering with the advancement of my device. So here we have the Landerquist wire. It's a very stiff wire that we use for these procedures and also for TAVI procedures, especially in the situation I have already described and known. Mostrame más abajo. So the wire is distally enough. Why we are not using Landerquist from the beginning? Because it's much more expensive. So if we can use the amplats, just 1 or 2 tries, it's okay. If not, we change. Once again, there is something there that prevents me to go in. Not good. Mostrame más arriba. Probably this tortuosity. And here, so here is important to see 2 different things. First, the device is in, and second, there is a coincidence between 1 knot and this marker of the distal end of the contralateral stump, where this, so it makes me sure that I have enough graft inside the main body. So there is some movement there, and now I'm gonna release there. So you see, I have at least 2 or 3 centimeters there. I'm gonna release completely, and there. And now we are going to prepare the second branch. So there is not, we can use an introducer here, a big introducer, but these branches are 14 French. If I put an introducer, it should be 16 or 18. So I would end up with a big hole here on the left comoral axis. So I would rather like to stay sheetless, or actually using the sheath of the device. But this stump can go into the main body sheath, but it's not possible to put the second stump through this sheath. I have to exchange everything. So once again, Juan is gonna hold the groin. I will pull everything out and introduce a second branch. So I think the time is okay. You have a second question. Well, for when you have tortuosity, Landerquist is the best wire to use for sure. In cases like this, I thought from the beginning that the amplats would have been okay. I don't know why I have this resistance to go in. The other is to catheterize the contralateral orifice. You have to use the CR4, the Lima, the amplats, or sometimes you have to try many catheters. In the worst situation, you have to go from brachial or humeral or radial or whatever superior access to snare a wire, to pull it, and to introduce the wire inside this orifice. But it's really uncommon, because if you are patient, you can do it. What is important for this contralateral orifice catheterization is to prevent, to deliver this stump against the border of the aneurysm. What I mean is, if you have an aneurysm, something like this, and this stump is gonna, it's gonna finish here, it's gonna be impossible to go here and then into this orifice. It's better to introduce the device from the other side. I don't know if I am clear enough. So here, I am not sure. This is the minimum overlapping I have to do. And I think I am distally enough into the external iliac artery. The wire you see outside is the wire protection we have from below. Yeah. Now, Carlos is gonna push the wire a little bit. With lander quizzes, you have to be very careful about not kinking. Okay, so I'm gonna help you. I'm gonna pull and you introduce wire. Combination, combined maneuver. Being very careful of not kinking the wire, because if not, you are going to lose the position. Now we can balloon in here. Probably we can use the Coda balloon to, try to get a better contact with the artery wall on the external and also on the joining, or I would say connections between main body and the first stump, and then the connection between the two stumps. The areas of overlapping where it's very easy to see on the floor. So this is a highly compliant balloon, Coda balloon. You have to inflate. There's a sensation. There is not pressure. It's a sensation that you have that you are inflated enough to get a good contact against the artery wall. So I would like to ask for more questions or comments. If you have, if anybody in the audience would have chosen a different strategy, here it's important to let somebody knows to be here and to hold here. Because when you are pushing the balloon, sometimes you lose the position and this hydrophilic sheath goes out. And this is not good. So here, probably the position is not that good because it's moving. The other question probably is why we are using regular SENI device and not the alpha. In this patient, probably it's not too much important because he has huge arteries. The alpha device is a very low profile device. Here you see I have problem there. So probably I would have used another balloon, probably low profile balloon. Give me un balón de 10. Yeah, you see, I have problem to advance there. So Carlos will retrieve it. So we inflate there with a 10mm balloon. Probably we have a kink in there because it's in the middle of the aneurysm. Okay. Please prepare this. For this balloon, we will need an indeflator. Okay, we still have 25 minutes. Please go as fast as you can. Let me check where we are distally here. I think we are not distally enough. We might need another. I think we still have blood flow into the aneurysm. So probably we should use another extension. Yeah, you see, this is the problem. So we will put another extension. Yes, a 13/64. So before inflating there, I'm gonna fix. This is the reason why the distal ending zone was moving, because was exactly at the border of the aneurysm. Could have been a little bit distal my implantation? No, because I wouldn't have done enough overlapping. So without the good overlapping, probably it's not a good idea, because when the aneurysm is completely sealed, then with the shrinkage, hopefully I say, okay, it's gonna decrease the size, and then it's gonna change the orientation, and we might lose the position if we are not distally enough. So, Juan, please, let's go to the other side again. So I have to retrieve this sheet. Please hold it. And then, and let's go with the third branch. So this is, unfortunately, we didn't have a stamp of 120, which could have been probably the solution, but not sure, because we are still in the aneurysm. So here you see, I have good overlapping there. Hold the sheet, please. No, stay there. Because the sheet is almost, yeah, it's almost out. So here, 1 or 2 centimeters overlapping, and then we are on the external. I'm gonna push the sheath, because if not, we in any movement we can lose the position again. It's okay. Avanza la guía, Carlos. Sí. Claudio asked me a question why I didn't push all the system further just to facilitate the balloon advancement. Let me see if I cannot advance the balloon. Give me the other balloon, the coda. Give me the coda. Oh, give me this. Okay, let's inflate once, and then let's go with coda. Why Juan is there holding from here? I'm here because if this sheet moves out, we are going to have huge bleeding. If you don't lose the position with the wire, it's not too much important, but it's not nice for live transmissions. So it's okay. So let me do, okay. Let me do something like Claudio wanted, but in a different way. So with the using the balloon, I could advance the sheath and I can dilate here. It is okay. So now the sheath is in the body, using the balloon as a introducer. Something that we use in radial or in other situations. So let's go with the coda to inflate the proximal body. We only have 15 minutes. We have to do this and to implant the homolateral stamp to finish. And then the closing the groin is not important. We have done a lot of cases during these live transmissions. So which is going to be important is to see if we have reached a complete sealing of this aneurysm. Probably in my prediction, there's going to be like a porosity. Meanwhile, we have a paralyzation on board. So here, once again, it's a sensation in your hand that you are inflating enough. You don't have to push too hard. You know, when the balloon is getting this quadrangular figure, it's okay. So Carlos is gonna pull it. Yeah. Let's go. Let me, excuse me, Carlos. Soltame un poquito el sheet. Let me do one here with this balloon. One here. And one distally. And then I'm gonna advance the sheet again. Okay. Deflate, Carlitos. Deflate. Okay, leave it there. So Dr. Carlos is gonna pull the balloon. Don't push. There it's okay. Okay, leave it like this. No, don't hold it. We have to be very careful because this wire is very dangerous. Now, show me here. Now I have to release the second security here, this button. And then the wire here is to release the distal part of the graph. I'm now holding the gray. Now, so I pull the sheath and the device is released. Now, panoramic, please. I open here. Dr. Fo is gonna hold this part of the device. I can advance the gray to recapture the nose. Now the nose is recaptured. I'm closing. Carlos is gonna push the wire. I'm gonna retrieve everything out. Oh, be careful because zoom. We are moving the device. You see, something is not okay. Let me, don't move too much. So, let me see. No, we have this movement. I don't like it. I rotating the device. I have a safe pulling. Now, let me see where is the introducer. Excuse me, the introducer is too distal. Let me put there and push the wire. So you always have to be very careful about pulling. Sorry. The delivery system like any other delivery system, because if not, you can dislodge the graph or move the graph from proximal part. Give me this one. Okay. Oh, it's okay. No, it's okay. It's okay. Give me some contrast. I'm gonna use, yeah, let me do a test and then we are going for mapping. So we will see where it's gonna be our distal landing zone. Contrast again. Once again, it's okay. So probably the distal part is here, where is the calcification. Please, mapping. No, it's even distally. Okay. So here we are. We have planned to use a 74. Excuse me, 24 distal diameter, and which is the 90. And 90. Yes, perfect. Let's go. Let's go. That we still have only 10 minutes. So let's do it here. So in front of the camera, the distal cap, we release this part of the device and then the protector inside, we flash. Good. Put up. Okay. To take all the bubbles out. And once again, in this side, you can go through the main sheath. ¿Cuál es la medida de este sheath, Alejandro? ¿La del cuerpo? No, del sheath, del set, del introductor. ¿Qué diámetro tiene? No. So this is 22 French sheath. Now I'm introducing the, hold it here. Once again, to prevent any distal movement. So I'm gonna, yeah. So here is where it's gonna be the distal landing zone. So I'm gonna do ancho to see that I have enough overlapping. The marker is inside the distal stump. The distal part is above the bifurcation on the road mapping. So here I am moving the distal part. This is the darkest part. Saca el mapping. So without mapping, you will see much better. Okay, perfect. So now I'm move this, introduce it a little bit in. Carlos is gonna retrieve, leaving the wire inside. And give me the pigtail and just to do an ancho. Be careful with this. To have an idea of where we are. Give me the pigtail, Carlos. Panoramic. So, because we still have 10 minutes. I think it's, yeah. So the question is, which would be the antiplatelet treatment in these patients? We use DAPT. There is not a specific studies like in the coronary field. If the patient has contraindication, we can only use aspirin. But if we can, we might use aspirin and clopidogrel for at least 6 months. If the distal, sorry, give me the pigtail is still out. If the patient has contraindications, the patient can only be on aspirin. It's okay. You don't need anything special. Hold it. Hold the sheath. Give me the shear for el Sharkin. Sorry, it was a too short wire. That's why I lost the position. I'm going to use the shear 4 and the hydrophilic wire. And then I'm going to exchange for amplats or something like this. ¿Tenés? No. Okay, hold the wire. Okay, give me the hydrophilic wire. Oh, it's okay, it's okay. Okay, hold the wire. Okay, have the pigtail in, give me the amplats. This introducer, the valve is not that good as the other introducers. So you might have some bleeding as we have here. Sorry for that. So now, Carlitos, retrieve the catheter and leave the amplat wire there so that we can introduce the pigtail. Any other question, Andres?
Yes.
Okay, great. Yeah, the surgery was considered, but remember he has a significant hepatopathopathy, probably a cirrhosis. The patient also has this orthopedic problem. So surgeons were a little bit reluctant to operate him, having the chance to do this endovascular procedure. Okay, 25. Okay, give me a second to see where is the pigtail.
Sorry.
Okay. I don't know where is the pigtail. It's so obvious that catheters are not too easy to see. So we have to aspirate because both iliac arteries are almost occluded. So we are not going to have distal flow. So if we don't aspirate, we are not going to realize how is the flow. You can do it. Okay, apnea. Don't breathe. Check. Aspirate. Beautiful. I think the outcome is really beautiful. So the patient is still under hyperinization. So we only have to close the groins. There's maybe some type 4 leak due to porosity. They are near to the carrefour, but not anything else special there. So I think we are done. So we still have 5 minutes. We are going to wait for heparin reversion, Carmen. We can give protamine. Give me the Amplatz wire. We are going to close this groin with a prostar, leaving a 6 French sheath in, just in case we need to do something else. Leave the Amplatz inside. Okay. Now we might need exactly and move the table to your position. Now we have to recover all the threads that we have here. Will you zoom here? I have. So this is something that I did in advance. This is the wire for protection, which is going to be kept there, sorry. And now I have to identify the white and the green thread. So this is the white. I'm going to do the first knot, but without pulleys tightening. Probably you can use the other camera, this one, not this one. The camera which is in front of me. Okay, leave it here. Don't do anything. The 6 French, where is, okay.
1 minute left to the transmission.
Okay. I am told that I only have 1 minute. Please, Carlos, hold it, please. Hold it. Okay. Let me put the 6 French. Give me 1 second. The case is absolutely done. But if we can complete the closing, it's going to be okay. Now I am tightening this suture. As you can observe, we have bleeding, but not too much. And having the 6 French, you can still use an angioseal here. And also the Amplatz wire that I have inside is a problem, especially in heavily obese patient, because the angulation of the skin. So let me see. I think everything is almost okay. We still have some oozing, but not that much. So we can pull everything out. Do you agree?
Yes, I agree.
Do you like to use the angiosil?
I think that it's close.
I would like to use the angiosil. Give me one angiosil, 8 French angiosil. Just in case, because the patient with hepatopathy probably platelet angiosil 8. I would like to be on the safest part. Whatever I am done, please let me know. I will say bye.
We are just waiting for you to say goodbye.
Okay. So let's see. I am put here. We have still some oozing, but the patient is heavily obese. We have a previous retroperitoneal hematoma, so we like to be sure that the closing is perfect. So I'm gonna put this angiosil and then we are closing the contralateral side. I think the case is already done. I thank you to everybody for having us. And also I apologize again for changing for this emergency case that hopefully was interesting for all the audience. So bye-bye. See you next week.